We will start with Dr. Francesco Lopo. He is a consultant anesthesiologist and is the director of research in Anesthesiology Institute in Cleveland Clinic in Abu Dhabi. And he is going to talk about the EEG monitoring during anesthesia or perioperative monitoring of EEG. Dr. Francesco is originally from Portugal, and he was trained in Portugal and the United States, and he is a board director of the EuroSIVA. This is Society of Intravenous Anesthesia. Also, he is international advisory board in Neuros for neuroanesthesia and steering committee of the International Consortium for EEG training of anesthesia practitioners. This may be a little bit new society or new group just because EEG monitoring is not so common yet in anesthesia. His interest and experience in neuroanesthesia, perioperative brain monitoring, and the pharmacology of the intravenous anesthesia. Again, his lectures is EEG monitoring during anesthesia. Welcome, Dr. Francesco. I will leave you with Dr. Francesco now.
Thank you for your words. I'm very happy and pleased to be lecturing in this webinar. And it's, as you said, I'm from Portugal, but now I'm working here in Abu Dhabi. So my topic in this following half an hour will be about EEG monitoring during anesthesia. This is a conflict of interest with Massimo, although there's no interference with the content of this lecture. Okay. The big problem is that I'm giving the lecture from home, and I have my 4 cats around. They enjoy to play around here, so there's a high probability to have one of them playing around my computer. So at the end of this lecture, I'll try to convince you that in year 2021 we should monitor the brain with EEG during anesthesia. And for that, I'll try to review the reasons why we should look into the brain during anesthesia and surgery, and then address how to understand and how to use the electroencephalogram during anesthesia, and how we can optimize and get this knowledge and apply it to our patients. So in summary, I think that we may say that we should monitor the brain during anesthesia, but also during critical care to help us to titrate the dose and optimize the dosing schemes of anesthetic drugs, to preserve physiology, to prevent and to detect critical events, to guide several treatments that we have to do, and then in the end to tailor anesthesia and critical care management to the individual requirements of each patient in different moments. So that's something that all of you know, guys. So we have this problem in anesthesia, the pharmacokinetic and pharmacodynamic variability. What is okay for me, it's not, probably it's too much or too less to Dr. Yasser. So we have this PKPD variability issue. And although we know all the pharmacology and pharmacokinetics and pharmacodynamics of our drugs, I think that we miss a lot how to measure the clinical effects of our drugs. For example, if we use the clinical assessment, it's not enough. For example, when there is a intraoperative awareness, it was only with 10% of cases with increase in blood pressure, 7% of cases with increase in heart rate, or only 2% of patients move. So, and movement is not at all way to look if the anesthesia level is adequate or not. And for those who use inhalational anesthetics, for example, using end-tidal values of volatile agents or using MAC, well, there are also some issues here. There is a significant variability between blood and end-tidal partial pressures of the volatile agents, especially when we when we want fast change in the inspire concentration. That's something that we know since long time. And also there's something that we know since long time is that MAC has intervariability since the first study of Eager in 1965. So you see each of one of these lines is one of the 12 dogs that Eager used to describe the concept of MAC, and you see there is a significant variability between the 12 animals here, but also inter-individual variability. I mean, like each animal, the MAC changes over the time. So the question is, can you imagine the brain made of millions of neuronal cells, millions of neuronal networks? Do you think that this organ is happy when we promote anesthesia? Do you think that general anesthesia is a physiological state for the brain? I do not think so. And it's quite strange that during decades, even today, in many places in the world, anesthesiologists use what we called the Leonardo da Vinci paradigm. That after it said that tears come from the heart and not from the brain. We explored this concept in this editorial published in the supplement of GCVA 2 years ago. And that's true. So what we do is to look to surrogate parameters like blood pressure, heart rate, and we do not look into the primary organ where our drugs act, which is the brain. Luckily, in the end of the 90s, year 2000, with the beach, and then all those scales of alertness or depth of anesthesia, I think we start to do a lot. Okay, cool. So all these dimensionless scales of anesthetic consciousness, we can call them that. So it's like a scale. Like the patient is a submarine here on the top, so fully awake, 100, and then we increase the concentrations of the anesthetic agents, for example, propofol. So we bring the patients to the bottom, and so the number is 0. Great. It was a big advance. We start to look into the brain during anesthesia with a different way. It was great. It was a great advance. However, probably the patient is not a submarine. And there are many limitations to these scales. There are many situations when the number says the patient is okay, and the patient is okay for surgery, the patient has a good anesthesia, the patient is talking with us. And opposite, we have many situations when the patient, the number says the patient is awake, the patient should be talking with you, and the patient is deeply anesthetized. We review these limitations in this paper 10 years ago, but it's still actual. So the idea is that we have to move forward. So from this window open into the brain, I think that we need a wide balcony to a wide landscape of the brain function during anesthesia and surgery. And EEG is that tool. Electroencephalogram is very well associated to the cerebral metabolism, allows the measure of the cerebral effects of the anesthetic drugs, allowing the individualizing dosing schemes, helps to control systemic variables like PaCO2 or blood pressure. EEG is sensitive to common causes of cerebral injury, detects neuronal dysfunction at a very reversible stage, and obviously is the best approach to detect epileptic activity during anesthesia. So EEG, you know, since the medical school, EEG is coming from these postsynaptic potentials on the cortical neurons. These action potentials come from the thalamic connections from these pyramidal cells between them, but also connections with thalamic cells. So these pyramidal cells are displayed like that. So here we have the surface of the skull. So it's like these neurons, they smear an electrical signal here on the surface, and we can record this electrical signal. It's great. So the idea is I do not want to have anesthesiologists able and skilled to read the EEG like our colleagues of neurology or neurophysiology. The same principle that we apply to EEG, to electrocardiogram. We know the basic, we know how to do it, how to apply for our everyday practice. And for difficult cases, we have the cardiologist. So the principle is the same. And the basic of the electroencephalogram is to know the different oscillations, okay? So we may record on the scalp these very slow oscillations, these delta oscillations from 0 to 4 hertz. I mean, it's the number of times that wave repeats in each second. Then you have the theta waves, the alpha waves, and the beta waves. So all these waves are normal. All these waves appear during sleep, during awake states, but then and may appear in different stages of general anesthesia and sedation. And then we have this pattern of burst suppression, like a flat EEG interrupted by this very fast and high amplitude activity. So this is not normal, and we'll go back to burst suppression again. So burst suppression is not normal and should be avoided during anesthesia. We just published this review paper. It's going to be open in 2 or 3 days. You can check for that. I think we did a narrative review about how to use EEG during anesthesia. So the idea is to count the peaks and valleys in each second. So here we have 1, 2, 3 until 10. So this is an alpha rhythm. If we go here above, and if you want to count, it's much faster, a higher number of peaks and valleys. So it's a beta rhythm. So if you want the delta, very slow oscillations, the theta, the alpha, and then the fast oscillations, the beta. And then you may have the gamma oscillations, for example, very typical when we have high doses of ketamine. This is the pattern of burst suppression. Please take a look on this with more attention. It's like a brain arrest. That's what I call it. It's a brain arrest. If you see this during your anesthetics, please reanimate this brain. It needs to be recovered. This is not healthy, as you are going to see. So, for example, here, we can see the 2 waves that are very typical of propofol. So you can see it's 1 second, 1 second, 1 second. So in this second here, we have this wave, this very slow oscillation, that slow oscillation, and then you have a superimposed alpha rhythm. 1, 2, 3, 4, 5, 6, 7, 8 peaks and valleys. Okay, so this is a typical pattern of propofol anesthesia: slow delta oscillations and a superimposed alpha rhythm. Then we have different channels. Okay, so we have 2 places where we have the places where we place the electrodes. We measure the difference of the voltage of these. So we have 1 channel, and different channels may have different activities. Also during general anesthesia, there are an homogeneity of the rhythms during the entire heads. So just for you to have an idea, so this is the EEG of an awake patient. This is in the operating room. You just arrive, you place a sensor in the forehead of the patient, you have a frontal montage. You see that very fast beta and gamma oscillations. They're very, very, very fast and small amplitude oscillations. Then you start to give a target control infusion of propofol, for example. You start to see the patient is moving, start to speak, and you see this, there is an increase of beta oscillations. And then you start to, and then you increase even more the target of concentration of propofol. The patients start to be more sleepy, but still awakes when you call his name. So you see here the alpha rhythm here, the sleep spindle, and then very fast activity there. So you have already alpha and slower oscillations, but still the high oscillations there. And then you reach with higher concentration, you reach the anesthetic dose of propofol. So you see the slow oscillation, and then above you have the alpha oscillation there. If you have no patient, if you give a huge bolus of propofol, you have only these very slow oscillations, or even burst suppression or isoelectricity. It's a good slide to make a screenshot to remind of. So, but it's okay, it's too complicated. Let's simplify this, okay? So monitors are able to, in every second, they quantify the different kinds of waves that we have. So in this second, you have this very slow oscillation here that you can follow with the arrow here, and then you have the alpha wave. So you have these two waves at the same time. And then every second, the monitor quantify the amount, the power of each wave. And then in the end, they can construct this spectrogram. It's every second, the monitor has this power spectrum. So the higher the amount of one wave is on very warm colors, red, orange. If the low power, the lower amount of one wave, of one frequency, you have cold colors. For example, here, so we have this 1 second. The second is filled with a slow oscillation, this peak here, you see the frequencies, and then with less amount, but still significant, the alpha frequencies peak here. So this, in this chart, so in this spectrogram, you have this black line, you have this strong red there, and that is this peaking of the slow oscillation, and this not so strong red, but still red here around 12 hertz. It's this peak of the alpha oscillation. It's a typical spectrogram of the EEG. So different drugs, different signatures of the EEG because they act in different neuronal circuits. So they have different patterns in the EEG. You see how that propofol and the sevoflurane, the dexmedetomidine and ketamine are different. Propofol, as I said, typically induce delta oscillations, alpha oscillations. Why? Because propofol induces a hyperpolarization of interneurons between the thalamus and the cortex. So the cortex and the thalamus only speaks through these long, inefficient thalamocortical neurons. And this communication is quite redundant, okay? So these long neurons are not efficient. So it's like the cortex and thalamus speaks like, it's like that. There's no communication. And this hypersynchrony between the thalamus and the cortex generates the frequencies around the 10, 12 hertz typical of propofol. But propofol also induces delta oscillations. Delta slow oscillations are generated by all the anesthetic drugs. Because anesthetic drugs, there's an impairment of communication, of connectivity between different regions of the cortex. So we may have neurons in upstate there, neurons in a downstate there, so they don't communicate. But also, and it's very interesting because it comes from the 30s, last century, from the experiments by Bremet, who was a neurophysiologist in Belgium, sadly, experiments done in cats. So what he did was to separate the spinal cord from the encephal, and then here to separate what they call the cerveau isolé. And if the cat was here, the EEG recorded was like an awake appearance. But if the transection was done on an upper place, so there was a rhythm with very slow oscillations. So anesthesia, what does is to separate the brainstem from the cortex and the subcortical structures, generating delta waves. Sevoflurane has a very different pattern, induces also very significant amount of theta waves. And you see, this is an anesthesia with the sevoflurane, the spectrogram of sevoflurane, and look how it's different of the anesthesia by propofol. Ketamine acts on the interneurons, also between the cortex and the thalamus, but through NMDA receptors. So there's an excitement of these interneurons. So there's a high frequency oscillations induced by ketamine. And if you combine propofol and ketamine, it's very interesting because they compete for the same interneurons, okay? So the winner is the drug with a higher concentration. So if we have propofol first, then delta alpha waves, we start the ketamine infusion, and you see there's a decrease of the power of the alpha waves induced by propofol. And then we stop the infusion, the ketamine is going to be cleared, and we resume the appearance of anesthesia of propofol, and the reverse. So you have the infusion of ketamine, we give a bolus of propofol, and you see that there's a decrease in the power of the fast wave. Here we had a stable anesthesia with the propofol. We gave a bolus of 0.5 milligrams per kilo of ketamine, and you see what happened. So there was a increased power in the fast frequencies induced by this bolus of ketamine. Dexmedetomidine, it's very similar effects like the sleep, okay? There's a hyperpolarization of neurons coming from the locus coeruleus, and with the projections to the preoptic area and other subcortical and thalamic areas, but also to the cortex. So there's a decrease in activity of these noradrenergic pathways. So what we have is something very similar with non-REM sleep, okay? So we have this activity between 10 and 15 hertz, but if we increase the concentration of propofol, we just have, again, very slow oscillations. And this the power of alpha activity, and I'm just reaching the end of the lecture. The power of the alpha activity is very well associated with the concentration of the drug. So for example, here we had a TCI of propofol, target concentrations of 6.6, and you see delta alpha. I decrease the concentrations to a low level there, and a lower concentration, and you see that here it's not so powerful as before. So even there's an increase of faster frequencies. And then I increase again to 5, and you see here, though, so it's not so strong as in the beginning, because, okay, 5 is less than 6.6. We just published this case report that was the lack of alpha activity with a normal index in the monitor, okay? So the decrease of alpha power was not enough to increase the index. But what was happening is that after a change in the syringe of propofol, the anesthesia nurse forgot to restart the pump. And the pump didn't alarm. There was a technical problem in the alarm of the pump. So the patient was, the delivery of propofol stopped for a while. And it was this lack of alpha activity here, was this thing different in the spectrogram that's called my attention. And so this could be due to nociception stimulation, but no, it was not. It was the infusion of propofol that was stopped. Burst suppression, please, again, it's very easy to recognize this. So burst suppression is not normal. Only happen when the brain is sick, metabolic encephalopathy, toxic infectious encephalopathy, traumatic brain injury, intracerebral bleeding, or when the patient hypothermia, deep hypothermia, or when the patient or someone is under the effect of high doses of anesthetic agents. And burst suppression is an impairment of production of resting, of an impairment of the production of resting levels of ATP by neurons. So neurons also, under the effect of general anesthesia, they have a resting production of ATP. And burst suppression is translating a failure on that energy production. So it's not normal. In the spectrogram appears as a black, and all these areas are black. So long time with burst suppression. So if you want to read something more about burst suppression, useful, not useful, not useful, again, it's a brain arrest. It's like you have to resuscitate this brain. You can see this review that we published in the beginning of the year in the best practice and research clinical anesthesiology. Just to finish, just to call your attention, that's a big limitation, an important limitation of the index of like BIS, PSI, entropy, all those numbers, key con, all those numbers. They don't have idea about the age of the patient. And the truth is that old patients, they have a low power EEG. So the waves are there, but with a lower power. The amplitude of the waves are much smaller. So the algorithm that is going to be used to construct the number is going to be affected by these artifacts. It's not a real artifact, it's how the nature is, okay? So for example, see this patient, 79 years old, the brain tumor surgery, we place here, respecting the 10-20 system for placement of EEG sensors, and you see this EEG, what you think that this is? Any clue? So you see what I was talking about before, flat EEG and this fast and high amplitude, it looks burst suppression, right? Okay, burst suppression. What are you going to do? Because that guy from Portugal working in Cleveland Clinic, Abu Dhabi, told that burst suppression it's dangerous, so you are going to decrease the concentration of your anesthetic agent. Wrong. This is not burst suppression. This is the EEG of a very old man. So you see the scale of the amplitude of this trace, 25 microvolts per millimeter. If you decrease to 10 and then to 5, you have the good anesthesia, even very deep with these very slow oscillations there. And the same for the spectrogram. So you see that this corresponding to the alpha there, so it's not very well visible. So if we decrease from 10 to 5 decibels, you see it much better. So the old brain works slower, and so you have to personalize the EEG monitor in order to adapt to the age of the patient. So you just adjust the scales. Two more issues about how useful is monitoring the EEG during anesthesia. If you detect a low power of alpha activity during anesthesia, this may be an alert for development of the delirium after anesthesia. So those patients who had a low power of alpha activity during anesthesia, they have a higher risk to develop delirium after surgery. And this is very important complication of anesthesia and surgery. And the same during the awakening part, you see, if you start to be familiar with the spectral analysis of EEG, you start to recognize, and I'm going to show you how you can learn this into detail. You can start to recognize different patterns during the awakening. And different patterns means different short outcome. So, for example, if the patients go directly from this pattern of slow wave awakening with a dominance of delta activity directly goes for this alpha activity and then awake, it's going to have a very smooth awakening. But if imagine this pattern here, 4, or this 6, the higher risk to have delirium after awakening. So if you recognize this pattern here maybe this 4 here, this 4 and this 6 pattern, you may try to change the course of the things. A small ball of dexmedetomidine, for example, can help, and you'll try to have a smoother awakening. Okay, and EEG also may be helpful to detect nociception. And the problem is that to have nociception detected by EEG, it's because the anti-nociception that you are doing, it's quite inefficient. So, and the brain replies to a nociceptive input on 3 ways. With a beta arousal, it's like the patient starts to be awake. No, he's still unconscious, but is feeling that nociceptive stimulation. Or the patient may have a delta arousal. So there is a paradoxical, it's like the patient is deeper and you didn't change the concentration. It's not very common, but may happen. Or you have only a decrease in the alpha drop, in alpha activity, something very similar as that case report that I showed you. That could be nociceptive inputs. And for example, here you can see this alpha dropout here after nociceptive inputs. And patients who had more time with slow activity during awakening are those who are going to have more pain in the package. So if you see a patient awakening with a long time with slow activity in the EEG, please optimize the analgesia. Just to finish, 3 platforms where you can learn about this. This EEG for anesthesia.iars.org. It's made by Emery Brown and his group in Boston. The step that I'm a member of the steering committee, a lot of presentations in Prezi, some videos. And if you want to see the lectures of this symposium that we organized in Porto 3 years ago, the lectures are free in this YouTube link. You are free to see Emery Brown and other lectures about this topic. So thank you. I think I'm on time for 5 minutes questions. Thank you for your attention. You have my email address, and you can contact me wherever you want. Thank you very much.
Yeah, thank you so much, Dr. Francesco. It is exactly 30 minutes. So you are very accurate. Yeah. Have maybe a few questions. The use of this EEG monitoring, especially in neuroanesthesia or a patient with craniotomy or a patient with head and neck surgery, is it difficult to apply the electrodes? What do you think?
Well, this is a very good question, and the truth is that it's paradoxical because in many times we listen our colleagues say, "Oh, I don't do neuro, I don't need to monitor the brain." But the brain is always under anesthesia, so we act even for other surgeries. So we, those as you and me, that we are more involved in neuroanesthesia, we have the big problem of this conflict of space with neurosurgeons, right? So where to place the sensors, and that's a problem. So I think that if I look back, so I finished my residency near 2000. So I have 21 years after finished my residency, and I never had a patient for craniotomy who had a EEG sensor. my view and my practice is, first of all, a very good relation with the neurosurgeon. So the neurosurgeon should understand that monitoring the EEG during the craniotomy, it's going to help to have a good outcome for his patients. This is the first point. We have, in many moments, we have to explain them this issue. And then we have to tell the patients, sometimes we may have, so where to place the sensor, okay? I think that we should respect, and I show you that patient with that parietal temporal montage. So luckily that patient had no hair, was bald, okay? But in some patients, my view is that good relation also with the patient. And then I explain to him, look, the neurosurgeon is going to shave parts of your hair to perform the craniotomy. Me, as a neuroanesthesiologist, to do a good job, to take care of you, of your brain, I need to shave another area of hair, to place the sensor that is going to help me to guide my anesthesia. That's what I explain to the patients. And I never had patients who refused to do it. I don't know if here in Abu Dhabi, I'm going to find a patient like that. I don't know. Till now, in Portugal, in US, and in Qatar, I never had it.
Yeah,
it's a question of communication.
Hemodynamics on EEG is that it may interfere with the level of sedation or pain. And supposed to be I have hypotension and this reduction of the cerebral perfusion pressure, and sure there will be some EEG change. Okay, so normal reflex from me, I will reduce the anesthesia either inhalation or intravenous. Correct?
Mm-hmm.
Okay.
Yes.
So yeah, how to judge this problem, the change in the EEG with hypotension or hypoperfusion and the adjustment of the anesthetic at the same time?
So what I think is that, yes, cerebral hyperperfusion induces a slowing of the waves of the EEG. But to have a decrease in the frequencies of EEG by hypoperfusion, well, you need to have a real severe sustained hypotension. If you have a doorway hypotension during 1 minute or something like that, I do not expect to have a severe change in the EEG. But if you have a sustained severe hypoperfusion, then yes, you may even have a burst suppression. But it's not common like that.
Okay. Maybe the last questions about the effect of ketamine. It may interfere with EEG or bispectral index. What do you think?
Well, what I think about is that, so yes.
Can you wait for a while, Dr. Safa, please? Can you?
So now the speaker is sharing the screen now. Okay, so the ketamine, it's very interesting because we know since the beginning that the BH was increased when we give ketamine, and it makes sense because ketamine, as I showed, increases the waves in the high frequencies, so beta and gamma frequencies. So there's a limitation of the index of the number. But if you start to learn how to recognize the waves, when you start to recognize and understand the spectrogram, that's it's the only way to see. For example, just to finish, just let me, I always talk about this. Now
so using ketamine without problem,
yes, but we use now in many cases what is called the low dose of ketamine, right? Like anti-nociception, anti-inflammatory effects. But what is a low dose of ketamine for you and for me? Ketamine has a significant pharmacodynamic and pharmacokinetic variability. 0.2 milligrams per kilo of ketamine in many patients is too much. So the only way to identify the low dose of ketamine is to have an EEG without changes. So you have propofol and you still have alpha and delta, you start the ketamine or you give the bolus of ketamine. If no changes in the EEG, it's the low dose of ketamine.
Okay, yeah. Small questions. Can we use EEG during CPR to guide the return of cerebral circulation?
Yes, I think the scientific evidence is much stronger regarding NIRS as a cerebral oxygenation using near-infrared spectroscopy, O3, INVOS. It's much stronger as a predictor of outcome, but we also know that if we have a patient undergoing CPR, if we have since the beginning burst suppression, the outcome it's going to be much worse. So yes,
it's going to be. Anybody does this trial or something? The using of EEG during resuscitation?
Yeah, there are some studies. There are some studies of value of EEG as a predictor of outcome after an oxycoma. Yes, and it's well shown that if you start to have a patient that needs CPR and then you recover the spontaneous circulation, but the patient stayed in a post-oxycoma, if the EEG activity is mainly of slow waves, the outcome is going to be very poor. Several papers showing that.
Thank you so much, Dr. Francisco.